tissues embedding. Okay, so once you have clear with
R0
the
resection.
margins, the section you have done a flap, what else would you like to do?
So I would like to subject the patient to adjuvant radiotherapy.
Would you like to investigate the patient for metastasis?
Yes, sir.
So what investigations would you like to do?
So metastatic workup would include a X-ray chest and
Yes.
ultrasound of the abdomen,
Yes.
and some people also like to go for a bone scan.
Yes, bone scan. That is an important thing because a lot of these lesions will not be picked up. Nowadays, any latest investigation?
PET scan.
PET scan. So how does it work?
So PET scan works on the uptake of the tissues of fluorodeoxyglucose,
Okay.
and it is a nuclide
What is the
study.
principle behind it?
So a more active tissue will have a higher uptake of fluorodeoxyglucose.
So what are the
like-
limitations?
So sometimes even an inflammatory lesion, if it is
Yes.
present, it picks
Usually
up,
the cancer cells, they are the metabolic rate is high in the cancer cells, and the FDG glucose is specifically picked up by these cancer cells. But the fallacy can be in an inflammatory tissue that can be done.
So, but in those cases, there will be an earlier washout of the FDG, whereas in malignant tissues, it will persist for a longer time.
Persist for a longer time. Okay, so the patient has got a few metastases. Say you get workup before surgery, and the patient has got a metastasis in a, say, lung, or one metastasis you can detect in a liver. Will you still like to go in for a surgery, or will you like to defer it?
So I would like to defer the surgery. We can put the patient on a neoadjuvant chemotherapy, a cisplatinum-based chemotherapy, and we would wait for the response. If but if the local site is bothering, and to reduce the tumor load, we can still go in for a surgery at a later stage.
Treatment will still remain the same, because metastasis as such, we have to take a control of the local regional control of the disease has to be there, because once these things fungate and patient forms a cutaneous fistula, it will be very difficult. Patient will be a social outcast. No one will be able to sit on that. So we have to take the local regional control.
So do we subject the patient to neoadjuvant chemotherapy, or we straight away go in for surgery?
Local regional control has to be done first. Neoadjuvant chemotherapy for a local regional control, supposingly it is extending beyond and involving the pterygoids, or the patient is having trismus, then we can use the neoadjuvant. If the patient is surgically manageable, we like to go and directly manage the patient surgically rather than going for a neoadjuvant. We can further subject the patient to radiotherapy after surgery for the local regional control. That is, can we subject this patient to radiotherapy?
Primary treatment by
Yeah.
radiotherapy? Yes, sir. It can be.
In such a ulcerated, no one will give you radiotherapy. It is such a ulcer, the radiotherapist, they try to cover. Usually if the lesion is small, say it's 2 centimeter, 2.5, they can go in for a primary modality for the radiotherapy. But in such a large lesion with the ulcerations present and bleeding present, the radiotherapy they like to avoid, and they like to go in for a surgery, and then you can go in for a radiotherapy after surgery. So then after surgery is successful, there is no on your histopathology, there is the lesion has been successfully resected. Will you like still to do something, or that is okay for the patient?
So I would like to subject the patient to adjuvant radiotherapy because of the field, as we had the field
Yes.
cancerization changes which were mentioned, and also put the patient on a rigorous follow-up regular follow-up to look for any more lesions developing.
Would
at
you
a
like to
later
give
stage.
chemotherapy, or just like to give radiotherapy?
Just radiotherapy?
Just radiotherapy. So we are discussing if the surgery has been successful and the total lesion has been resected, will you like to just give radiotherapy, or would you like to give chemotherapy after that, adjuvant chemotherapy?
If the resection is R0, that's
Yeah.
what you're saying?
Yeah.
If the resection is R0, that is, there is no microscopic evidence of remnant disease, then there is an indication for radiotherapy based on certain factors. Now, the indications for radiotherapy in such cases include, number one, locally advanced disease. That is the disease which has gone beyond its frontiers, it has gone into the surrounding organs, or any T4 disease, let's put it this way, or poor grade tumor, right, or involvement of lymph nodes in the neck. It also depends on how many lymph nodes out or how many were involved. What is the optimum neck dissection in oral cancers? How much should be removed? When will you say that neck dissection has been successful? Anybody in the audience? You need to remove at least 10 lymph nodes from the neck before you call it adequate neck dissection. Now, if you remove 10 lymph nodes and more than 2 or 3 are positive, and if there is extracapsular spread, radiotherapy has to be given. Then also, if there is, in any case, if the disease is R1, you're going to give radiotherapy. Now, what was the stage of the cancer, Rohan? What was the?
So T3 N1B N0.
Now T3 N1B M0. Okay. Now with T3, you don't really suspect that there would be R1 resection. That's what you think.
So,
Now, if you have an R0 resection and no nodes are positive and the tumor is a good grade, then radiotherapy can sometimes be skipped. What are the contraindications to giving radiotherapy?
so the involvement of the mandible.
One is involvement of the mandible and
So when the patient is not fit to receive radiotherapy, the general condition of the patient does not.
what do you mean by that? Performance status.
Performance status.
So use the term specifically, poor performance status. When the patient is not fit for a haircut, you can't do surgery, can't give radiotherapy. So if the patient is going for radiotherapy, he has to be fit for it. Any other contraindications to radiotherapy, audience? No, well, that would be an indication. We have resected it now. We are believing that we have caused the resection is adequate. Patients suffering from collagen disorders, radiotherapy is contraindicated in any case, right? But by and large, radiotherapy is given generally to locally advanced oral cancers where there is a suspicion of extracapsular spread, where there is poor grade tumor, there is angiogenesis, and there is a lymphovascular invasion. These are the indications, right? How would you reconstruct can you show me your patient again, please?
Yes.
There you are. Now describe this quickly. This lesion, how big is it?
So it was a 5 into 2 centimeter lesion extending from just.
That's fine. So
just-
is it involving the skin or skin is free?
Skin is free, sir.
How do you know the skin is free?
So
What test did you do to
you can
find?
pinch the.
Could you? You have an outer view of the same patient? Now, if the skin is free, what resection are you going to do? You're going to leave the skin or you're going to take it out?
So there was an area on palpation. There was an area of induration. So.
So, if there is induration, would you call skin free or you'll consider it involved?
Consider it involved.
Difficult to pinch it, no? So, if you're resecting it, how are you going to reconstruct it?
So I'm going to
Unless
reconstruct.
Dr. Pawan has covered that part.
I talked about
What are you going to do about reconstruction?
So I'm going to use a pectoralis major myocutaneous flap for the inner lining and deltopectoral flap for the outer lining.
Now, what's the problem with that? If you use can you do something better? How old is the patient?
A 52-year-old lady.
52-year-old lady. If she was 42? What would be the best way to reconstruct? Let's look at the best way.
You can do a free flap.
Free flaps. Now, what free flap would you use in this patient? Suppose you were to use it. Any free flap? Just think of any free flap.
A radial artery.
Radial artery forearm free
forearm
flap. Okay. Now, would that be preferred in this patient, or you'd go for these axial flaps from a distance? What is the problem with these axial flaps? You know what is an axial flap?
Yes, sir.
What is an axial flap?
So axial flap is one which is rotated on a known blood supply.
Name a few axial flaps.
Deltopectoral flap, pectoralis major myocutaneous flap.
Okay. Now, what is a random flap?
A random flap is one which does not have a named blood supply.
Now, what's the disadvantage of a random flap?
So the doubtful doubtful vascularity of the flap.
Okay, and so doubtful take up.
So
You can't trust it. If you can't trust it for anything, then it's not trustworthy. Now, free flap versus axial flap, that's what I was trying to ask you. Now, you prefer to use a local flap or a flap from a distance here? Is there any other alternative? You said DP and PMMC, isn't it?
Yes, sir.
What is the feeder for DP?
So, perforators of internal mammary.
And for the peckless major myocutaneous flap?
Lateral thoracic, which is a branch of thoracoacromial.
Lateral thoracic is a branch of
I'm
thoracoacromial?
sorry.
Lateral thoracic is a branch of which artery?
Sorry, sir. Lateral thoracic, which is a branch of a second part of axillary artery.
Tell me the branches of axillary artery. First part?
First part gives.
First part, one branch. Second part, two branches. Third part, three branches. First is supreme thoracic. Second as thoracoacromial and lateral thoracic. And third as anterior and posterior, circumflex humeral and subscapular. Now, can this be based on, does lateral thoracic supply pectoralis major?
Sorry,
Audience, what's the
lateral pectoral, which is
pectoral branch of thoracoacromial artery? Right, so it is actually what? Can you repeat it?
pectoral.
Pectoral branch of thoracoacromial artery. Now, what will be the disadvantage of using this flap? It will be very bulky for such a small defect. I was wondering for this reason. And it will always need to be, there is some amount of morbidity when you take it from one place to another. How about the local flaps? Can you use a local flap here? Any flap from here?
Based on the superficial temporal.
Yes, forehead flap you can
Forehead
use,
flap.
which can be used for outer or inner lining, and you can use a platysmal flap for the inner lining. Now, when you are reconstructing, what all factors you take into consideration? Generally, comfort of the patient, and the why not free flap in elderly patients? What's the problem?
So the vessels can undergo atherosclerotic
So you
changes.
may not be very sure about the blood supply. That's correct. Now, when you are reconstructing this patient, it is therefore necessary to make sure that the neck also is covered, because what type of neck dissection you have planned on this side?
So
Have you
modified.
planned a neck dissection?
Yes,
It's N1 disease?
N1.
Okay. What neck dissection have you planned?
Radical neck dissection, a modified radical. So we'll go in for a radical neck dissection, but if the structures can be preserved, we would do a modified radical
Which
neck
one you
dissection.
would like to preserve first? If you
So in order of priority, the spinal accessory, internal jugular, and the sternocleidomastoid.
Okay. Now, when do you think you can't preserve them?
So when they're encased or they're involved.
Directly involved by the
Yes.
tumor. So if you can preserve, you would like to go for. Tell us about the modified radical neck dissections.
So we
various
could
types.
include dissection of the level 1 to level 5 lymph nodes,
Preserving what all
preserving the
structures?
spinal accessory, internal jugular.
So that will be type 1 is when you
Type
preserve
1 is
spinal
spinal
accessory.
accessory. Type 2 is when spinal accessory, internal jugular vein are preserved, and type 3 is when spinal accessory, internal jugular vein, and sternocleidomastoid.
Okay,
muscle.
you're right. All three. Now, in this case, if suppose you remove sternocleidomastoid, you've done radical neck dissection. Now, what is the problem subsequently? You're going to give the patient radiotherapy also.
So the carotids will. There's a risk of carotid blowout because
Good.
they'll lie
There is
exposed.
a risk of carotid blowout. So, how do you prevent it?
So we can do a platysmal tunnel.
One is the platysmal tunnel. How is it done? What is the platysmal tunnel?
So it is. We use the platysma to create a cover over the carotid, so that it.
It becomes a compartment in itself, okay? Now, and if you're using a PMMC flap, it covers it automatically. So there is an advantage of PMMC flap if you're going to give radiotherapy subsequently. Now, this really helps. Otherwise, you should be careful. If sternocleidomastoid is preserved, then you are not so much bothered. Now, moving on to the adjuvant therapy, as Dr. Pawan was asking you, what are the indications for giving chemotherapy in head and neck cancers, particularly oral cancers? Would you give it routinely or you don't?
So we don't give it routinely.
Why?
So because the response is not very good.
Now gradually people are trying to find the response. Now, which regime from the audience which regime is mostly followed in head and neck? Gemcitabine based regimes are used to improve the response rates, but chemoradiations are used gradually. They are in use. They are using it for locally advanced disease or where you cannot resect it. What will make this case inoperable?
So involvement of
No, this patient has no problem. You see the primary is clearly visible. Now you can go back to the primary. Now primary looks resectable. So your trismus and other things are not there. So what would make this case surgically non-resectable? Can you think of something which can make it surgically non-resectable?
So the patient can be inoperable because of
Oh
the
yes, one
poor
is the patient
performance
is not
status.
fit. Your performance status comes back again. If he's not fit, I am repeating, if he's not fit for a haircut, don't do a commando. Right? And how about the neck nodes? Can they make the surgery not possible? What is an non-resectable case? Forget the inoperable. Quickly tell us.
Non-resectable case would include the involvement of the pterygoids,
Yes.
the retromolar trigone,
Yes.
the base of the skull,
Right.
and any vital structures in the.
No, if the lymph nodes are encasing the carotids,
Carotids.
they're involving the skull base, they're involving the vital structures, it becomes impossible to clear it. So that also becomes non-resectable. That's what I was trying to know from you. Even this patient can become non-resectable. It's not always the primary that makes a surgery difficult. You may have a second, the lymph nodes can be causing the problem. And in addition to that, if the patient is not fit for surgery, this is what I was trying to say. Now, if the patient is otherwise fit and everything is all right with him, you would like to go for a wide local excision, which ends up here being excision of the tumor with a margin of about 2 to 2.5 centimeters. Some people take 1.5, but 1.5 to 2. 2 is optimum, with a clear resection of the margin, the R0 resection, and right-sided modified radical neck dissection. The presence of a lymph node, it's safe for a postgraduate to answer radical neck dissection. Right? Now, radical neck dissection is mostly indicated wherever the nodes are fixed, or they are fixed to surrounding structures. There is extracapsular spread. So it's safer to say radical neck dissection unless the nodes are free from the vital structures. So this was a case of locally oral cancer with lymph nodes, but it was resectable. That sums up the case. Thank you.
Thank you very much, Dr. Sundanari, Dr. Rohan Khandelwal, Dr. Kamal Lal, and Dr. T.K. Jana for being with us in our studios and telling us about a case of buccal mucosa. We will be back in our last session after 15 minutes, and in that particular hour, there is a lot about examination of head and neck cases. There will be conclusions, there will be questions, there will be discussions also, but for that you will have to wait. Till then, keep watching Gyan Darshan.